So we will go ahead and get started. And for some reason, if Dr. Spergel is late, then Dr. Mukada will start off the conference for us. But I want to thank you all so much for being here tonight. My name is Ellen Kodroff. I'm the president and founder of CEGIR. And on behalf of Shay, Kyle, and myself, we welcome you here. And we're glad to offer this conference tonight free of charge because we believe in making support and information accessible to everybody. We want to especially thank Takeda for being a sponsor for this evening. And a special thank you to Julie Daisy, because without her help, these conferences probably would not happen. She's a very big part of it. And Julie Daisy works at Cincinnati Children's Hospital. We also want to especially thank our speakers for this evening, Dr. Vince Mukada, Dr. Simon Zhang, and hopefully Dr. Jonathan Spergel. All that being said, if you're finding value in what we're doing tonight, and if you're in a position to give, we'd be incredibly grateful for any donation, large or small. Your support helps continue this work and reaches more people than ever, and your support really does make a difference. And even if you're not able to donate right now, there's another powerful way that you can help. Consider hosting a fundraiser for CEGIR or a Facebook fundraiser. Something small in your home, a gathering with family and friends. Like I said, every little bit does help. These personal fundraisers really do make a difference, and we can help you get started with templates and tips. You can just email Shay or myself. Shay will drop a link in the chat now for donations if you're able, and with our emails, both of our emails. And please just let us know if we could help you. And Shay is going to give us some housekeeping information for this evening.
Good evening, everybody. I just want to give you some tips on to help move things along and be respectful to our speakers. If everybody could place their speakers on mute unless you are asking a question or the speaker, we would greatly appreciate that. When you're asking a question, please do not make it case specific about you or your child. Doctors cannot give medical advice, so we will have to skip your question and we won't be able to have it answered. And that goes for in the chat or live. Also, if you can also remember to, you can also raise your hand when we do question and answer. That's going to be after the speakers speak this evening, and you can ask it live or we can ask it for you in the chat. And with that, I think we're all set to get started. And Ellen, has Dr. Spergel joined us yet?
No. So Dr. Mukada, do you mind starting us out?
Great. All right, can I go ahead and share my screen?
Yeah, you should be able to click on share.
All right, hopefully this will work. Let's see. All right, can you guys see my slides?
We can.
Okay, and audio wise, things are going okay? You guys can hear me?
Yes. Perfect. The slides are not in presenter mode though, but if...
I will hopefully get that.
Okay.
Switch over there.
But you sound great.
Okay. All right, guys. Well, thank you for inviting me for this to give this talk. It's an honor to be with you guys, and in honor of National Eosinophilic Awareness Week. So I'm going to try to give a practical guide on how we're using Dupixent or dupilumab in eosinophilic GI disease. And we'll kind of go through what we do, but and I'm happy to answer questions, in the chat or as we go. So, and then certainly in the question and answer. But if anything I say is unclear, please stop me so that I can clarify. All right. So usual disclosures. I will be discussing off-label use of medications, and we'll be talking a little bit about dosing of meds as well as we go through this. And so I'll start with just giving an overarching framework for how we think about managing pediatric EOE, but really EOE in general. We will talk about Dupixent or dupilumab in particular. We'll talk about some of the side effects, and then we'll end with a discussion of what we're actually doing with it, how we're actually using it. And so, starting with these kind of big picture principles. So what's our overarching goal? It's to prevent disease progression over time. And I like these two figures. This is one of the original manuscripts about eosinophilic esophagitis by one of my predecessors here in Cincinnati, and from 2004, and it still holds true that the presenting symptoms tend to progress as kids get older and go into adulthood, and starting with the less specific things like feeding issues and vomiting and pain, and moving more towards trouble with swallowing. And that correlates with what we see on the other side of this image here, where we have this nice kind of cartoon view of what we see through the scope, and how that looks with the diameter of the esophagus. And you can kind of think of it as typically the kids that have problems with feeding issues and vomiting and belly pain tend to be more on this inflammatory side of the equation. And as you get more towards food impaction and dysphagia, you start seeing narrowing of the esophagus and stiffening of the esophagus and stricture. And that's what we're trying to interrupt. And then we want to balance that always with the need to make shared decisions, right? So this can't be a process of me telling you exactly what you need to do, or you telling me, oh, this is the only thing that I'm willing to consider. Because again, there's not a one true way to treat the disease, but we like to think of it as this is what's working best for a family at this moment in time, and that can change over time. And so, first big decision is always diet versus medications. We're obviously going to be spending all of our time today talking about one of the medications, but this is kind of where we start. And again, the plan can change over time depending on your patient's response, different preferences over time, what works for you in that moment. And this is really a day-to-day discussion. Every time patients come in to see us, every time we have phone calls, this is kind of underlying everything that we do is that shared back and forth discussion over what's motivating you, what's your goal, what works for you as a 7-year-old with eosinophilic esophagitis may be a totally different equation for the child living down the street. And as a pediatrician, one of my big goals is always to figure out both what the goals and motivations of the family are, but also the patient, and trying to negotiate between the two when those two things are in opposition. But it is important to have that discussion up front to help with everyone buying into the plan and reducing the frustration that we can feel over the long term if people don't feel heard. And so, again, this is you guys have seen this image before, but this is where we started in 2022 with, this, I remember giving this talk, variations on this talk in 2022, and it was this, this exciting new hope and first treatment for eosinophilic esophagitis. And to where we are now, where dupilumab has actually entered into the most recent treatment guidelines from the ACG. And so we'll talk a little bit about that arc and really how we actually position dupilumab now. Most of you know this, but just as a review, how does it actually work? What does the drug do? So it's an IL-4 receptor binding agent, which blocks two cytokines. You can think of those as like immune system chemicals. So IL-4 and IL-13. It's a subcutaneous injection, as you all well know. It was first approved for eosinophilic esophagitis in patients that are 12 and up and greater than 40 kilograms or 88 pounds in May of 2022. Then in 2024, it was approved for ages 1 and up and greater than 15 kilograms. And that was January of last year. And it has indications for multiple other things. So eczema or atopic dermatitis in patients age 6 and up, asthma age 6 years and up, And both of those were approved before eosinophilic esophagitis, as it was for allergic rhinitis with nasal polyps. It's also for prurigo nodularis, and then most recently for chronic urticaria. I initially had this thought I was going to show all of the different dosing regimens, and then I realized it was quickly overwhelming. But all of these indications have different dosing regimens, and and we will talk about that a little bit and why we do what we do here. But you may see people being treated for different conditions whose doses seem different from what you're used to. And just not to, for family-oriented talk, we don't want to spend too much time looking at graphs here, but just high-level overview from the initial phase 3 trial that saw Dupixent getting approved originally. So what we see here is significant improvements in histology, so what we see under the microscope, endoscopic scores, so what we see through our scopes, and then when we look at a transcriptome level, you saw normalization of the esophageal transcriptome, and it was equivalent in both weekly and every other week dosing of dupilumab. The difference was we only saw significant changes in the DSQ symptom score in weekly dosing as opposed to every other week dosing, which is why the approved dose in the patients ages 12 and up is weekly dosing. And then there's a follow-up study Dr. Rothenberg was the lead author on from now 2 years ago, looking at 230 adolescent and adult patients that from that initial group that showed similar results, that persistent improvement in histology, endoscopy, symptoms, and the molecular transcriptome, they persisted or actually even improved at a year of treatment in the patients on weekly doses, but the symptomatic improvement was still greater in patients on weekly dosing than on every other week. And so, that's kind of in the broader group of eosinophilic disease. What about the patients that have the most severe cases, the advanced cases that were more on that kind of right side, the stricturing or narrowed side of the equation? So there's been several papers looking at patients with fibrostenotic disease. Evan Dellen's group looked at a group of 46 patients with refractory disease, so the disease that wasn't responding to other therapies, with fibrostenosis, so narrowing of the esophagus, that were treated with dupilumab. 80% of them had their peak eosinophil count drop below the magic threshold of 15 eosinophils per high-powered field. EREFS, which is a standardized score to look at how what we see through the scope, those scores also significantly dropped from 5 to a little bit less than 2. The mean esophageal diameter, so kind of the diameter across the inside of the esophagus, actually increased, which is what we want, obviously. Although the number of patients or the proportion of patients that had strictures didn't change, at least they were widening it somewhat. And then this 91% improvement in a global symptom score. So it was a different symptom score than the DSQ. And that may be relevant as we go farther in here, and we'll talk about that again as we go. And this is kind of what it looks like. This is a different case report, and this is actually in pediatrics. So the top images are patients with stricturing disease pre-Dupixent, and then what you can see below are 2 images after dupilumab therapy. You can see the rings that we see in these, and the top image. And the narrowing of the esophagus has significantly improved. You can now see smoothly down to the lower esophageal sphincter. Things have clearly improved markedly. So even in patients that had developed advanced disease, we can see improvements. What about going beyond the esophagus? So if we look at more generalized eosinophilic disease or eosinophilic disease below the esophagus, and this is one of the parts, as I said before, where we're talking about off-label use of these medications. They are only, dupilumab is only approved for the treatment of eosinophilic esophagitis at the moment. But this is just some evidence that's out there in the literature about using it for eosinophilic gastritis and eosinophilic duodenitis. So this is a case series from Dr. John Leung's group in the Boston area, looking at 12 adult patients who had eosinophilic gastritis or duodenitis, 8 of whom were started on dupilumab and then had endoscopic follow-up within the study period. So 75% of them improved in at least one of their symptoms, and you can see the symptoms listed there. 4 out of the 4 patients that had eosinophilic gastritis and had a follow-up scope that they included had remission of their stomach eosinophilia, and then 4 out of the 6 who had scopes done who had duodenal eosinophilia had remission on their dupilumab dosing. This is another case study. This is a single patient actually, but I like the images here. So this is a pediatric patient with eosinophilic gastritis and duodenitis, if I remember correctly. But it's interesting to see. So this is a group of patients that has that we see sometimes with persistent duodenal ulcers, as you can kind of see down on the lower left there. And at the top here, you can see they were treated initially with our kind of traditional therapy of systemic steroids and trying things like PPI and elimination diets. And with that, initially, when you're on systemic steroids, you saw the ulcer getting smaller, you saw significantly less eosinophilic inflammation. But then when the steroids were weaned off and trying to treat with just the elimination diet and PPI and Montulacast, the ulcer came back, inflammation started to recur, and that only got better once they were treated again for a course of time with prednisolone and then remained on dupilumab, which was started during the prednisolone dosing. And even after the steroid was weaned off, they continued to have resolution of their ulcerating disease, and the inflammation was basically gone. We're back to baseline levels of eosinophils in the esophagus. So again, some evidence that at least in some patients, dupilumab may have efficacy and even in more distal eosinophilic disease. Again, in picture form, another case report. This one is from the pediatric world, so looking at patients with eosinophilic duodenitis and gastritis. So you can see kind of redness and ulceration very clearly getting better here after treatment with dupilumab. And again, based on these results, as well as some other scattered case reports, there have been bigger trials underway. So the DEGA trial through CEGIR, the data will be forthcoming in a manuscript, but the study is complete. And there is the industry-sponsored trial, which is underway as we speak. So hopefully more to come for using dupilumab in treating eosinophils even beyond the esophagus. So this all sounds great. So what's the downside? What's the possible negatives here? Let's talk about adverse events. And my children are still allowing me to show pictures of them in presentations, so I'm just trying to take advantage while I can. Let's see. So we have for adverse events. So it is generally a well-tolerated drug. So most common site injection reactions, so redness or swelling at the site. Nasopharyngitis or upper respiratory kind of infections are can be seen in up to 1/5 of patients. Headaches have been described, loose stools, arthralgias or joint pain are infrequent but can be quite severe when it happens. Transient peripheral eosinophilia, so your blood eosinophils going up, seen more in the trials for asthma, eczema, and chronic rhinosinusitis. Not seen very much in the eosinophilic esophagitis trials. We haven't seen much of it in clinical practice, thankfully, although we do continue to monitor. More rare side effects, so neutropenia, conjunctivitis, depending on the disease that you're treating. So it was seen more often in patients that were treated for eczema or atopic dermatitis. But obviously many of our patients with eosinophilic esophagitis do have eczema as well. So we definitely have seen some patients with conjunctivitis. More significant eye inflammation like uveitis can be seen more rarely than conjunctivitis. The development of psoriasis has been reported. We have seen it in a couple of patients. I do think in at least some of our patients, what we have seen is the dupilumab seems to treat all of their eczema, and then patients have been left with some psoriatic lesions that in hindsight, they said were likely there all the time because they were always patches that felt a little bit different, but now that the eczema on top of it was gone, you can actually see the psoriasis. And then dupilumab associated facial rash, which is this kind of red rash that you can see on this patient on the right, that is a characteristic but rare facial rash that we have seen once or twice here in Cincinnati. Does tend to get better when coming off of dupilumab. It can be, people have tried treating it with other with some antifungals and antiparasitic medications that occasionally work. Interestingly, we have seen one patient who had that facial rash that was pretty significant enough to stop the medicine, who ended up going back on dupilumab several months later and actually never had recurrence. So it's a little bit odd to know exactly what was happening there. This one I bring up because I think I have heard about this several times from patients. I think it's obviously concerning, but there's some caveats here. So this is a manuscript from 2023 from the Journal of the American Academy of Dermatology, where they looked at a retrospective cohort of patients. It's a little bit of an interesting study in the sense that the matching was the numbers in matching was a little bit strange. So 23,000 atopic dermatitis patients treated with dupilumab versus over 1 million who had not received dupilumab. They did see an increased risk of cutaneous T-cell lymphoma, a total of 41 cases in patients seen with dupilumab, but then interestingly, a reduced risk of melanoma and basal cell carcinoma. So the more dangerous skin cancers actually seem to be reduced in risk, but this is again a retrospective look. The increased risk persisted, although it was lower, because one of the concerns was, well, maybe it's other drugs that were being used to treat these patients. Oh,
Yeah.
sorry. Oh, sorry, was there a question?
If everybody could place their microphone on mute, please. Sorry about that, Dr. Mukada.
All right. Sorry. So the increased risk persisted even when they excluded patients that had been treated with other anti-inflammatory drugs. So, but given the retrospective nature of the study, it's showing association, not causation, which is always important to say. And there have been subsequent studies looking even at the same data set that question whether dupilumab was unmasking an underlying T-cell lymphoma, as opposed to, so the eczema went away and you actually saw the underlying disease, as opposed to being associated with the cause of the disease, similar to what I described with psoriasis, actually. And when I talk to my friends in dermatology, they have said we have not seen this as a significant issue, and they don't seem to be as concerned about it. But obviously more to come. Sorry, hang on one second. What is in here? Okay. And then potential for relapse on dupilumab. So we have thankfully have not seen this very often, or I'm not sure that I've seen it at all in my patient population, but Dr. Hirano at Vanderbilt reported a patient that was a 17-year-old boy who did have refractory EOE in spite of steroids, went into remission with dupilumab, which was actually started for his eczema. They tried taking him off of his corticosteroids, and he flared back up again. So the dupilumab alone was not enough to treat his eosinophilic esophagitis. Went back into remission when starting on corticosteroids. So we have seen a few patients who do seem to need combination therapy, even with dupilumab, and this is another one of that type of patient population. So all of that's well and good. So theory is well and good, but what does this mean for what we actually do? So few practical tips. Again, going back to that overarching view of things, even in the era of dupilumab, we still offer all options to families. So we still do diet therapy for many. We do less and less often do the more extreme diets than we used to. So we're typically doing a lot of one food elimination diets or step up diets. We still use PPIs or swallowed steroids as our first line therapy. For the kids that do topical steroids, I typically use budesonide for my younger patients or in patients with severe asthma who need rescue inhalers. We use Flovent still or fluticasone in our older patients. But then dupilumab goes higher in my personal algorithm in the patients that have lots of atopic diseases. So as many of you or your children know, you can be on multiple forms of steroids. So it's not uncommon for our patients to be treated with inhaled steroids for their asthma, swallowed topical steroids for their esophagus, antihistamines, Montulacast. So if you're getting treated for multiple things, it's probably worth considering a single therapy that might help with all of it. In general, as I think many of you who are our patients know, we have started our patients at biweekly dosing rather than weekly dosing. So generally we have seen good results and low side effects, and we're working on writing up our data right now. But with all that being said, if patients are doing well on treatments that we have 20 years of data on, so, all diets, PPIs, swallowed steroids, we don't necessarily, I don't feel a pressing need to push people to do the new things. I think that it's nice to have more options. Our experience, so again, we start our older patients at 300 milligrams every other week. Last time I presented this to you guys, we had about 250 to 300 patients. We now have more than 400 patients on this medication, and we're still so far continuing with the same trends. It seems to be working well for us, minimal side effects. We have had to updose to 300 milligrams weekly in a few patients, but generally it's been older and larger patients, so maybe more in line with the adult reported data. We're continuing to track these patients for the progress over time and to see if we will eventually need to titrate them upwards. And again, this may highlight differences between the patient-reported outcome scores and then actual clinical experience. The DSQ that was used in the studies focuses on dysphagia, which we don't see as much in pediatric patient populations. So that may be part of what we're seeing here. And I will also say, for the benefit of some of the folks that are on this call, I was resistant to this initially. We have tried dupilumab in some patients who seem to be in remission, but we're still having persistent symptoms and have seen significant improvement in several of them. And I think it's probably because they globally feel better with better treatment of their other allergic disease. So I think some of them are sleeping better because their eczema is under better control and they're not itching. Their nasal congestion is better. They're not snoring. But regardless of what it is, we have had some patients who've done better than I thought they would just by switching to dupilumab. The other elephant in the room is that the shot does hurt. There's no way that I can sugarcoat that from what everyone has told me. It is a pretty viscous medication, so it does take some effort to push it in when you use the pre-filled syringe. Some things from our practice that we've seen helping some of our patients. Interestingly, we've had a number of patients who've told us that if they take an antihistamine on the day before and the day of their injection, it seems to help with pain. Doesn't work for everyone, but a lot of patients swear by pre-dosing with Zyrtec. Icing the site, making sure the drug has come to room temperature for several hours. Anecdotally, it seems like doing the injection on the abdomen as opposed to the arms or the legs may be less painful, probably because there's more and looser subcutaneous tissue to inject into. The pre-filled syringe versus the auto-injector may be less painful for a lot of patients. We've had patients who've had good results with topical numbing gels or sprays. And then using distraction techniques, so the Buzzy Bee or other kind of vibration devices. I have a number of patients that really swear by it. And I also have a lot of patients who say, yeah, this injection, it's not good at all as far as the pain goes, but I feel so much better that it's absolutely worth it to me. So we do have to be very upfront with people and say, I'm sorry, I do have to tell you, it is a painful shot. You can do this, but it is a painful shot. And then just to end with a couple of practical pearls here. So even in the era of dupilumab, I think it's worth revisiting this. This is still a chronic disease requiring ongoing therapy and monitoring. It is very important to assess response. So symptoms alone aren't sufficient. We still recommend follow-up endoscopy to know that things are actually working as well as we think they are. There's still a role for surveillance scopes. So some kids may become resistant to their medications or outgrow their dose. Human nature would suggest that we all become less compliant with our medications as the longer we're feeling good. But here we don't necessarily adjust our doses just for growth until we see evidence of disease recurrence, because we definitely have patients who are still on doses that I would otherwise not have thought would work for them, but seem to be effective long term. And thank you, of course, for your attention. And then I'll leave it for questions at the end when we do our joint question session. And let me stop sharing. All right, if I can figure out how to do that.
Hi, I just have to interrupt. I am so sorry. I forgot to introduce you and let people know where you were from. Dr. Mukada is a medical director of the Division of Gastroenterology and a gastroenterologist at Cincinnati Children's Hospital and at the Center for Eosinophilic Disorders in Cincinnati. And thank you so much. That was wonderful. So Dr. Spergel, everybody, I'm going to let you know, is going to come on Friday night. So you'll be able to hear his talk still, but it's going to be Friday evening. So should we just do questions now for Dr. Spergel, and then we can get on with our next talk after that? Does that work for everybody?
Did you mean Dr. Mukada?
I did.
Yeah.
Thank you.
We can.
Do you want to go ahead and start with the questions, Shay?
Sure, I will. Dr. Mukada, the first one is, do you see acne breakouts with Dupixent?
That's a great question. I can't say that I've seen it happen more frequently. It's a little bit hard because a lot of the patients that are getting dupilumab in our patient population tend to be adolescents, and so it's a little bit hard to know, am I seeing acne more frequently just because they're adolescents or not? It doesn't anecdotally feel like I see it more often. I have heard people describe it for sure.
Okay, I'm going to read this question to you. When ready for questions, safe while trying to get pregnant. When ready for questions. Oh, is it safer when you're trying to get pregnant? She's asking. Safe during pregnancy, and if not, how soon should you stop it before trying to get pregnant?
So I hate to say this, I'm going to punt a little bit because as a pediatric GI doctor, this is not a question that comes up often enough for me. I would look it. I can and would look it up, to be very honest. So it's just not something that comes up to me. Maybe Dr. Zhang or one of the, I think Kathy Peterson's on the call as well. I thought I saw. So maybe one of the adult docs might have an opinion.
Sure, if somebody else wants to.
So this question has come up for some of my patients, and with the GI doctors I've worked with, they've generally recommended not being on the Dupixent while pregnant, and coming back after pregnancy to discuss starting or restarting.
Okay. She also asks the difference between recommending Eohilia versus Dupixent, and should you start the Eohilia first and then go to Dupixent if that doesn't work?
Yeah, it's a great question. I don't know that we have a hard and fast rule one way or the other. I think we are Eohilia is the other newly approved eosinophilic esophagitis treatment. So it's a pre-mixed budesonide formulation. I think it's a good medication for patients that don't necessarily want to go down the route of an injectable medication. So it's still an oral medicine. I have seen I think because dupilumab was available first, we haven't had this come up as often in terms of patients really making a decision between one or the other. I've had patients go both ways, though. I don't, I think it's the advantages, disadvantages. I think you have an injectable medication versus an oral medication. With the injectable medications, you're taking it once a week or once every other week, as opposed to daily medications. Both are still chronic therapies. Technically, Eohilia is approved only for 3 months. Our clinical experience with it is that it generally has been we've been able to get it approved by insurance if it's effective in a patient after the 3-month mark. So I don't, I think the other advantage, disadvantage. So Eohilia treats your eosinophilic esophagitis. It doesn't treat other allergic diseases. So again, for that multiply atopic patient where you may be able to treat their eczema, their asthma, and their EOE with one medication, I think in that setting, dupilumab makes more sense to me. I think there's also questions about looking at it. So can you eat whatever you want when you're on Dupixent, and do we monitor any blood work? So we typically will start. I'll do the blood work question first. So we typically will start. We will do a blood count with a differential to make sure that there's not that your blood eosinophils don't stay persistently elevated. We know a lot of our patients, if you check early, will have at least a slight rise in the peripheral eosinophil count. As long as it comes back down, I'm not too concerned about it. We will typically monitor blood count at around the 2 to 3 month mark on starting dupilumab, and then at least annually with endoscopies or at the time of endoscopies. But we have not seen a whole lot there. And then as far as the eating question, I think can you eat anything you want? So it does not change your risk for anaphylactic food reactions. So we definitely, you cannot eat your anaphylactic foods just because you're on dupilumab. As far as the foods that trigger your EOE, we're kind of working on that in real time. We have had a couple of patients. It does seem to certainly expand people's ability to tolerate foods. We've had 1 or 2 patients who have failed a food even when on dupilumab, but even in those patients, it generally seems like it's allowing them to eat far more than they could before. But with that being said, that is also true with successful treatment with steroids. Whether or not this is more effective than effective treatment with steroids in terms of allowing foods is hard to know. That's why we're collecting the data, I think. So.
Okay, the next question is, if there's no adverse effects appeared in short term on dupilumab, is there a possibility to show some later? If you go off of it and then back on Dupixent later, any indication that tolerance to this medication might change?
It's a good question. And the honest answer is we don't really know. We have had a handful of patients who have gone off and on the medication, as I think I mentioned, with the facial rash and for insurance reasons and a variety of things. So far, we haven't, to my knowledge, seen any adverse effects or any loss of efficacy. From my understanding from talking with representatives from the company, that they feel that it's a low potential for this drug has a low potential for causing antibody formation. So one of the things we see with biologic drugs like Dupixent, especially in our inflammatory bowel disease population, is that the longer you're on the medication, the higher the chance of developing antibodies or immune reaction against the medication itself. And so that runs the risk of then either the drug not working or having reactions. This drug does not seem to have as high a risk of that, certainly. I think I know that in the studies they did monitor that. We're doing a study here as well, looking at antibody results to see. But as far as we can tell, it seems like we can come on off of it to a certain degree.
Okay, the next question is, how soon do patients report symptoms starting again after stopping Dupixent?
It's so this is a very small number of patients that we have seen that have come off of it, and so I think that's really, it's hard. I would say the couple of patients that I've seen, it's usually has been within a month or two of stopping the medication. We have seen a lot of patients, or not a lot. The majority of the patients that have come off the medicine, which is a small number, have reported symptoms coming back after a month or two, not usually in the first few weeks.
Okay, the next question is, if someone is currently on a mast cell stabilizer like oral cromolyn sodium, would they need to continue that when starting Dupixent, or would Dupixent also act as a mast cell stabilizer?
So I don't know that it's going to be a direct mast cell stabilizer in the same way. With that being said, we have had a number of patients. So our typical practice here is to get someone in remission and feeling better. So I don't necessarily stop their other medicine. So when I start someone on dupilumab, I will typically stop their topical steroids if they were on it after about a month of overlap. Make sure that they're in remission, and then we will offer the opportunity to say, if you want to try to come off of your mast cell stabilizer, your antihistamines, your PPIs, any of those kind of things. I'd usually prefer to do it once you're feeling better, just to operate from a position of strength, and in that way you kind of know which one, if something actually was helping or not. But we do try to get people off of those drugs if we can. But they may be helping things other than their eosinophilic disease, and that's where that gets a little bit tricky.
Okay. Any reason why a patient that has eczema would have more of an adverse reaction from the Dupixent?
Again, I'll defer to people much more expert in the treatment of atopic dermatitis and immunology than I, like Dr. Zhang. But I think the question is, why would someone have the conjunctivitis risk? I don't know really, other than there may be more of a underlying barrier function dysfunction in some of those patients. But why that was reported, and again, this is just what's reported in studies, as opposed to knowing what's actually out there in the world for what people are actually seeing. But I would guess that it's something to do with the underlying tissue in patients who have eczema versus those who don't. I don't. Simine, do you have any other thoughts?
This question actually came up on another conference, and I'll defer to Dr. Spergel's expertise. And he previously mentioned that he thinks it has to do with like a under concurrent process that may be going on, and that Dupixent may have relieved some symptoms, but if something else, like if some of the eczema may be psoriasis and more, or like more Th17 driven, they may be revealed. So
yeah. Yeah, that's definitely been our experience, is that we've seen some patients who really do feel like, oh, I always had this. It's just now that the eczema is gone, I can tell the difference.
If someone is on a PPI long-term and symptom-free, but eosinophils still present on the scope, do you add another therapy?
So this is, I'm assuming this is pre-dupilumab. This is just kind of someone who's been treated long-term with PPI. They're feeling good, but there's still some eosinophils. That's a great question. That's back to that discussion that we started with it. That I think that is a back and forth. I've done different things with different patients. So I have had families or kids who've come in and said, you know what, I'm happy with what I'm doing. I'm not worried. I'm not concerned, or I'm not nervous about long-term effects of PPIs. This is what I want to do. And the agreement I usually make is, that's fine. I think that's a reasonable decision. But let's make sure that we at least stay seeing you in clinic. And my request is always, let's do another endoscopy after X amount of time, a year, 2 years, something like that, to see, is the disease getting better, worse, or the same? If you're starting to see scarring, if you're starting to see narrowing of the esophagus, I think that's a strong argument that you do need to change therapy. If you're still, there's some eosinophils there, but you're feeling fine, I think it's arguable whether you want, and you don't want to move forward on therapy. I think it's reasonable to kind of hold. I think there's other families or patients who come and said, I don't like the idea, I'm worried about this, or they presented with more severe symptoms and said, I never want to get back to that. I want this treated the most aggressive way that I can. I think that's also a not unreasonable way to approach it, but it's different for different people. I won't fault anyone for either one of those approaches. I will say that for the PPI question in particular, PPIs in general feel like and there's been published data that would support this, that the PPIs, people with eosinophilic esophagitis seem to lose response to PPIs more frequently than they do to other therapies. So I will say I've had patients who fit into this bill who then came back to me on a follow-up visit or called and said, you know what, I'm feeling worse. I think it's time.
Okay. On Dupixent, should patients minimize eating like the 6-food elimination diet? Should they, if that's what they were on, I guess, before being on Dupixent, should they minimize eating those 6 foods?
So I hopefully I don't pay the price for this, but my feeling on this is if you are agreeing to put yourself through a medication, with knowing that there comes with side effects and benefits, I think you should get the most benefit that you can from it and try to expand your diet. Certainly, as I said, we've had a couple of patients who still have a food or two that still sort of breaks through the dupilumab or breaks through the steroid, and they need to stay away from that. But I think if you're going to take the medication, we should try to expand your diet and improve your nutrition.
Okay, the next question is, do you hear female complaints of periods coming closer together when they are on Dupixent?
I have not. And I do ask the question, especially in my adolescent patients who are getting started, just because I was sort of interested in the question and whether we'd see anything. So I have not, but that doesn't mean that it doesn't happen. Again, as we see more and more patients on the medication, we will start to see some of these things that are rare side effects.
How often do you see patients who develop resistance or tolerance to Dupixent?
I don't know that I have yet. That speaks to something that maybe I didn't highlight enough in talking about this, which is one of the discussion points in deciding on initial therapy is the very reasonable question of what can you tell me about long-term effects? What can you tell me about what this is going to look like in 5 years, 10 years, 15 years? And the reality is we've been using the topical steroids, we've been using diet therapy for that long, so we have a better sense of what that long-term might look like. That's one of the downsides to dupilumab is, some of our patients have been on it because they started for asthma and eczema, have been on it 5 to 6 years, and it seems to be working great for them. And those patients seem to be, I haven't seen any resistance develop. The only question there is, as they get bigger, especially the kids that started at very low doses at a young age, they may need a higher dose. I haven't yet had a patient who had good response to dupilumab who has then stopped responding. We have had a couple of patients who've needed to go from twice weekly dosing to weekly dosing, where they told us, you know what, I'm starting to have symptoms sooner than 2 weeks, and maybe we should go to weekly dosing. But they generally have been bigger kids, adult size and large adult size, frankly.
Do you have any concerns about the medication during puberty? So right along that same topic.
Yeah. Not more than I do for about any medication in puberty. We haven't seen anything to make us concerned. And I think that's always the concern, or these are always the concerns that we have with starting with any new medication in pediatrics is I feel pretty good about how it works for the 5 or 6 years that I've seen it. I still have, I can't tell you conclusively that I know what it's going to look like in 20 years. But so far, we haven't, back to that question about periods and things, we have not seen changes that are obvious.
Thank you. Budesonide slurry versus fluticasone swallow. What's the criteria for choosing one approach versus the other? Really good question.
Yeah. So I have some personal criteria, I suppose. So I sort of rough estimate, kids that are 7 or less, I tend to use budesonide more for a couple of reasons. When you do part of it using a fluticasone or using an inhaler, you're asking someone to be able to seal very well with their mouth so that their lips can seal around so the medicine isn't coming out of the sides of their mouth. You are asking them hoping that they have a big enough oropharynx that it's not coming directly out of their nose, which can be hard even in small children who, even with perfect seal on their mouth, you tend to see this kind of Puff the Magic Dragon effect of the medicine coming out the nose. I think it's easier for the older kids to do the inhaler, and easier for the younger kids to do the budesonide. I think I have a sort of personal rule, which is if your asthma is bad, if you need to use your rescue inhaler a lot, I would prefer to keep you on budesonide, swallow budesonide for your EOE, and keep all inhalers to be for your respiratory therapy. And in the rare occasions where someone hasn't responded to budesonide and we have had to switch, I actually ask families to put a piece of red tape on their rescue inhaler, and actually have gone in a couple of cases have actually said, please send me a picture of it. Because the worst thing that can happen is you have an asthma attack, someone either panics or, grandma's watching and doesn't know, or the kid doesn't know, they grab the wrong inhaler and they try to use their EOE medicine, which will not help their asthma attack. And so that is always my fear there. And I've had a couple of scary cases like that. So I do try to use budesonide more in the kids with bad asthma. Other than that, I think the older kids do tend to prefer the inhaler because it's easier. They don't have to mix things. The advent of eohilia may make that a little bit easier. But when we had to pre-mix it all the time, I think kids are more likely to do. Older kids are more likely to do the inhaler. But again, we've seen some patients do well on one versus the other, and it's not always predictable. And failing one doesn't necessarily mean that you will fail the other steroid preparation. So good reasons to use both.
I think you might have answered this one, but it's phrased a little different. How long does Dupixent stay in your system when you stop? Karen, do you mean like for the whole week, does it stay in your system, or do you mean when you completely stop taking it?
When you completely stop, like I'm kind of going back to the pregnancy situation. Let's say you used it and then you said, okay, time for pregnancy. Like, would you want to be off of it for 6 months, or does it, I don't even know if it stays in your system. I know it's different than it's a biologic.
It does stay in your system. Again, I'm not a pharmacist to really be able to give a great answer there. I would typically say it feels like it starts to come down pretty significantly after the 2 to 4 week mark. So I would sort of roughly guess 2 to 3 doses worth, or 2 to 3 half-lives would be sufficient to get it down pretty low.
And
just based on when we see symptoms break through. But
is there the potential for rebound, like worse than before when you're on it and then you go off, and you may not have that data? But
I don't know that we have that data, to be honest. I don't know that we've seen necessarily worsening. And I think what we typically, again, very small numbers, what I've seen is most of these patients had been on it for a while, were feeling really good, and so when their symptoms started to come back, they started from a low level. So it's sort of, they would say it was a slow build. In the beginning, I was wondering, was it really the Dupixent? Is it really getting worse or not? And then it got worse.
Thanks so much for all your answers.
Okay, great. If in remission on Dupixent, how often should you rescope?
So again, and this is my or our personal practice. What I generally do is on any therapy, if you're in remission and not changing, so that your first scope in remission, let's say I do an endoscopy today, you're in remission, this is your stable therapy, you're not changing anything. I would typically do a repeat scope about a year after the initial one, and then depending on the child and the family and the situation, try to space it out to every 2 to 3 years from there. It's a little hard, especially in pediatrics, in the kids that are rapidly growing. I'm maybe a little bit less likely to space it out too long, just because they may outgrow their dose. But certainly in the adolescents and young adult patients, I'm happy to try to space things if I can.
Okay. What is the long-term therapy with a PPI, steroid, or Dupixent? What is safer? Sorry.
Oh, safer. That's that to be honest, I think that remains to be seen, because as we said, we know kind of 20 years worth of data on diet and PPI and steroids. We don't know that for Dupixent yet. They all seem to be, in general, they all seem to be pretty safe therapies. I don't, I think this is part of why we say this is a chronic disease. We don't want you just taking your medicine and disappearing on us, but in general, people have tolerated their medications pretty well. So I think I'm not, the sort of flippant answer is I feel a lot better about chronic therapy of these diseases now than I did 10 or 15 years ago, where we used to try to treat everyone for a limited period of time and then stop the medicine and see what happens. And inevitably what happened is the disease came right back. So now, with the benefit of that many years of seeing people on chronic therapy, I actually feel much better about it than I used to.
Okay, we skipped a question up here. Would you consider trying etrasimod once positive trials complete for refractory cases?
So I would. So I would. Now, I have etrasimod is approved only in 18 and up, and in ulcerative colitis right now. So as a pediatric GI doc, who doesn't specialize in IBD, I have actually zero practical exposure to etrasimod, other than knowing some people who have taken it. I think the data that's been reported is very exciting. So I think certainly etrasimod is something that people have thought about. I think refractory cases, there's some other things that are maybe on the horizon. In case someone asks about JAK inhibitors, I think that's another thing another potential medication that might be used in refractory cases and that will be studied here soon. But I think, so there are some options. There definitely is, as we always say, there's more hope on the horizon, but there truly is. So there's more to come.
Great, thank you, Dr. Mukada. We are going to move on right now to Dr. Simine Zhang, and she's an allergist at the Division of Allergy and Immunology in the Cincinnati Center for Eosinophilic Diseases. She's also a current CEGIR Hirano Scholar.
And Dr. Mukada, if you wouldn't mind staying on after in case there's more questions, and if you have to go, maybe you could answer the rest of the questions in the chat before you leave.
Hi, everyone. Can you see my screen okay? Okay. I'm Samine. Thank you so much for the introduction and for having me. I am a CEGIR Hirano Scholar, so I'm excited to give my talk today. I did also want to mention in terms of the pregnancy, the experience I've had with Dupixent and pregnancy in EOE has mostly been initiation. So those have been like put off, but in patients with like asthma and other indications where they've been really well controlled on the Dupixent, we tend to keep them on it because, you know, we figure that a flare would be worse than any side effects associated with the medication. Okay, all right. So today I'm going to be talking a little bit about mast cells and EOE. And so despite the name eosinophilic esophagitis, eosinophil depleting antibody therapies have not provided clinical improvement in clinical trials. And so this has expanded focus to other aspects of the immune system, including mast cells. And so here is a mast cell. These are immune cells that reside in peripheral tissues, including the esophagus. And they're known to be important in mediating allergies, including anaphylaxis, food allergies, asthma. And so as an allergist, I think a lot about them. So here is a summary slide of what is known, some of what is known about mast cells and EOE. So we know that they accumulate and increase in the epithelium in the esophagus. They do exist in homeostasis in the lamina propria and the muscularis mucosa, which are the deeper layers of the esophagus. They're associated with decreased epithelial resistance, increased epithelial permeability, and smooth muscle contraction. They've also been associated with certain histologic changes, including dilated intercellular spaces, basal zone hyperplasia, endoscopic changes, including edema and furrows, as well as symptoms including pain and dysphagia. And so, like I mentioned, mast cells are elevated in EOE. This is a paper from Dr. Abonia, but this has been shown from multiple groups. So you can see on the left that mast cells are higher in eosinophilic esophagitis compared to other chronic esophagitis, like other conditions of the esophagus, as well as the normal esophagus. On the right, you can see that this is the degranulated mast cells as a surrogate for mast cell activation. And that's what's shown in the arrows up here. So the aim of this research was to investigate whether there's increased mast cell activation in EOE, and our hypothesis based on previous research is that there is. We took a couple of different approaches to look at this. The first approach is something called immunofluorescence. So this is where human esophageal tissue was fixed, cut, and stained with antitryptase, which helps us identify mast cells. We then created this protocol called mast cell AI, which was used to identify them. And then we compared the total area of tryptase on a slide.
See, I can't get mine loud enough. In the car, I could hear it good.
Excuse me, if everyone could go on mute, please, if you're not speaking.
So we subtracted the total area of tryptase from the mast cell AI identified mast cells to see if there is increased degranulation. And then we compared this area between active EOE and control. So here's just a demonstration of that. So this was the development of this mast cell artificial intelligence protocol. And so this is a high magnification immunofluorescence staining of the human esophagus. This is the epithelium, and you can see the nuclei of cells in blue and the mast cells in yellow. And on the right, this is what we train to identify mast cells. So using this method, where we took all of the tryptase and subtracted the mast cell AI identified mast cells, we looked at the extracellular tryptase and found that the area of extracellular tryptase was increased in active EOE compared to control. And from this, we concluded that there's mast cell degranulation in EOE compared to controls. And so since this is a new method, we're now using other well-established methods to confirm our findings. And so what we did was we took fresh human esophageal biopsies by our experienced gastroenterologists, including Dr. Mukada, and then we digested them into single cell suspensions, stained them with fluorescent antibodies, and analyzed them by flow cytometer. And then we use these antibodies that are known to be on mast cells to identify them. We then looked at another marker called CD63, which increases with mast cell activation. So as you can see, CD63 lives within the mast cells, and then when there's degranulation, they then merge with the surface of the mast cell. So using this strategy, we identified human esophageal mast cells, and we were able to observe CD63 staining, which shows increased expression in active EOE compared to remission and control. And so based on this, we again concluded that there's increased mast cell degranulation in active EOE. And so then my next question was, what signals may be involved in this mast cell activation? And to approach this question without bias, I went back to the bulk RNA sequencing data. So this tells us about all the genes which are upregulated and downregulated in EOE compared to control. And CPA3, which is highlighted up in red, is one of the most highly increased mast cell specific genes. And we found that one of the markers which is most correlated with this was C3AR1. And so this correlated with multiple mast cell specific genes. So what is C3AR1? This is a receptor. It's a type of receptor called a G protein coupled receptor, and its ligand is C3A. So C3A is an aflatoxin, which is released during activation of the complement system. So this is another part of the innate immune system. And so this C3A is generated from cleavage of C3. And there are many ways that you can get C3A generation. And when C3A stimulates C3A receptor, it can activate mast cells, and it can also act as a chemotactic factor, so it can move them. So we looked at the expression of C3A receptor on mast cells in EOE, and we see that a large amount of them, the mast cells do express the C3A receptor. And in fact, the C3A receptor correlates with this marker of mast cell activation that we looked at earlier, CD63. And so based on this, we concluded that mast cell degranulation in EOE may be attributable to the C3A receptor. And so next, we looked at the ligand for C3A receptor, C3, to see where it may be of importance in the human esophagus. And we found that they're mostly in the fibroblasts. So that is a structural cell in the deeper layers of the esophagus. And you can see that this gene is actually increased in active EOE compared to control. And so fibroblasts are a local source of C3, and C3 increases in active EOE. And so the next thing we did was to see if there was increased C3A. So if there was increased complement system activation. To look at this, we looked at the protein for C3A, which is a marker of activated complement system, and also at C3 at baseline. And we found that the ratio of C3A over C3 is increased in EOE compared to control, and concluded that there's increased complement activation in EOE. So based on all of this, it seems like there is increased mast cell degranulation in active EOE patients compared to control and remission EOE patients. This activation may be through a non-IgE mediated mechanism through the C3A receptor, and that fibroblasts are a primary source of esophageal C3 and increases in active EOE. And there's also increased local complement activation in EOE. And so based on this, my next steps are to look at what are the effects of increased mast cell activation and complement activation in EOE. And that's all I have for today. So I would like to thank Dr. Mark Rothenberg and CEGIR, Cured, FAIR, and AppFed for sponsoring my research. And let me know if anyone has any questions. Thank you for your attention.
First of all, I want to clarify and just let all the patients on the call know that Dr. Zhang treats adults and teens. So if you're looking for an adult allergist, and she's at Cincinnati Children's, like Shay mentioned. I think there was a question here about the EpiPen that maybe you could answer. Now I got to find it. Shay, do you see that one? Oh, here. Have you come across Neffy epinephrine nasal spray as a new alternative to the Epi injector pen in children who have both food anaphylaxis and EOE? She's in the UK and says Neffy is currently going through review with the NHS. The practitioners say it can be used as it could can't be used as it could possibly flare the EOE. Is there any evidence that you have found to support that theory?
That's a good question. So I do have patients who have both EOE and food allergies. I can't say that I've had any patients who've used Neffy and had it flare their EOE. Dr. Mukada, I don't know if that's something you have experience with.
I have not. I actually, it's funny that someone asked that. I just started seeing my first few patients on Neffy the other day, and actually had to realize what it was because they just said Neffy and I didn't actually know what it was. So I haven't seen it yet. I guess again, more to come as we start seeing more use of that formulation.
Another question is do you recommend people follow a low histamine diet?
Oh, it's funny. I'll answer my part of it, and then I'm interested to hear what Dr. Zhang says. We do not. I just typed it in there. I don't routinely recommend it for an EOE, the EOE side of things. I think it was a companion question to the one about mast cell staining. So we don't routinely stain for mast cells. And I don't routinely recommend a low histamine diet. I think in patients who have persistent symptoms with the absence of eosinophils on their biopsies, we will sometimes do the additional staining to look for mast cells as well. And I don't routinely recommend low histamine diets, but Dr. Zhang is clearly much more expert on mast cells than I am.
No, I don't routinely recommend histamine diets either. I do have patients who have food intolerances with or without EOE who may feel better with histamine diets. And, for the people who feel better, I say, go with that. But there's no way to kind of right now have a biomarker or predict who will or will not respond to a histamine diet. And there is literature that mast cells are increased in EOE remission patients, and they do correlate with certain EOE parameters, but it's hard to say whether they are causal in those symptoms, and it's hard to say whether treatment will result in improvement and what that treatment may be at this point.
Okay, we have a question that is above. What are your thoughts on natural treatments that allow for a full diet? For example, healing the gut and taking natural supplements to control EOE.
I think I typed out an answer to this one, but it's sorry, I was just kind of typing as we went. So I think in theory it sounds great. In practice, I haven't seen it actually work. I think several of the folks on here are my patients. I'm more than happy to talk about it as long. I think one important thing I am very open to the idea of trying natural therapies. It is really, really important to tell your physician if you are doing it, just because we've had some unfortunate cases of people on natural therapies that have bad interactions with other things or side effects that we didn't know about, including herbal things that cause bleeding and endoscopy complications. So, I think I would love to say that we've seen great success with something. I can't say that we have, but open to the idea. But please be very open with your physicians and having that discussion.
So then it's probably.
I think we're a little lost on where the questions are, and we don't want to, if Dr. Mukada answered your question, then that's great. If you have another question that hasn't been answered, why don't you take yourself off mute or raise your hand and we can call on you. Either way, because I just don't want your questions not to get answered. So at this point, we're a little lost what was answered and what wasn't.
Yeah, I'll stop typing at this point. How's that?
Great. So does anyone have any more questions that they want to ask? Feel free to take yourself off of mute. Hi,
quick question. Curious to understand what you think about the new class of drugs looking at KIT inhibition in EOE, especially like barzolizumab, which are targeting mast cells.
I think for my, again, not mast cell expert by any means, I think they're more likely to treat symptoms. They're not necessarily going to treat the underlying inflammation, so that may or may not change the risk for things like stricture formation and those kind of things. I think that's when you look at the barzolizumab specifically, with the study for barzolizumab, the outcome measure is symptoms. It's not it's in histology, but only in histology with relation to the mast cells. It's not looking to reduce the eosinophil numbers.
And I think to add on to that as well, it's difficult because eosinophils are regularly not in the esophagus, whereas mast cells are. So mast cells are tissue resident cells which are present in homeostasis, and so it's harder to tease out what they're doing in homeostasis versus.
Excuse me 1 second. If you guys aren't asking a question, please put yourself on mute. I'm not sure where the sound is coming from. Sorry, go ahead. I hate to apologize.
Oh, no, it's fine. It's hard to say what they're doing in homeostasis versus inflammation. So that's one of the things I'm trying to figure out.
Okay, Caitlin Burke, Dr. Burke has a question.
Hey guys. Oh, I will fix my camera for tomorrow. So Samin, I had a question. I don't know why I hadn't thought about this before, but you're talking made me think about like non-IgE mediated like mast cell activation. And we already think about maybe I think about like things like the food-induced response of the esophagus and EOE as like maybe mast cell mediated, maybe like antigen specific. But I was wondering like more about sort of, we talk about like medications, like opioids, vanc, I haven't done adult allergy until like ciprofloxacin, like activating mast cells like through like MRGPRX2. Like, have you guys clinically seen at all like people who complain of sort of immediate type esophageal symptoms like with those type of like non-IgE mediated mast cell activating medications?
That's a great question. So, I think I've also thought a lot about how mast cells might be interacting with the environment and different foods, and for example, why didn't Xolair work, or why didn't that clinical trial work? And that's kind of what started my research into the non-IgE mediated space. But I think there's evidence from a couple of different groups, including the paper from Mirel, which shows pretty convincingly that there is increased local IgE. So there probably is IgE mediated activation. I will say when I personally looked for MRGPRX, I didn't find its presence in esophageal
I wonder if it's like
cells.
one of those like MC, MCT, like those things you make
Yeah,
for the boards.
I
Yeah.
looked in mucosal and connective tissue
Yeah.
mast cells and I didn't see them. But in terms of like that immediate reaction, her group, they have done some intradermals of foods in the esophagus.
Yeah, those
And
pictures are
she told me,
terrifying. Yeah.
and she told me that, some patients do have an immediate response.
Cool.
So I think there's just so much happening and there's still a lot that I don't know.
Cool. Thanks.
Dr. Zhang, are mast cells a result of EOE or do they contribute to EOE?
Again, I think it's part of them are there without EOE, and it definitely seems like they are activated in EOE. So I do think they contribute, and that's part of my research trying to figure out how and what they contribute.
Laura, you can ask your question.
Hi, everyone. If someone has been taking budesonide and pantoprazole for 7 years and is an adult now, is it preferred to stay on that, or like why are people moving over to Dupixent? Because it's so much more expensive too.
Right. I mean, from my perspective, I don't see a compelling need to make a switch just to make a switch. So if patients are doing well on the therapies that they're, whatever therapy it might be, budesonide, PPI, fluticasone, diet elimination, and they want to continue that, I think that's very reasonable. I think, again, with the couple of situations that I've seen patients who said, I was doing fine on my previous therapy, but I'd like to make a change. A couple of scenarios that have come up are, kids going off to college and saying, you know what, my day is different day to day. I'm not used to that. It's really hard for me to take my medicines the way I'm supposed to. This shot would be a lot easier for me. Or again, patients who have other allergic diseases that they're taking medicines for, that they'd say, well, I'd like to try this one thing to see if it might help with multiple things and reduce my total medication burden. But if what you're doing is working, I don't think there's a reason that you have to change by any means.
And then I got another quick question. Chronic really red lips, is that like a sign of an allergy or with no other skin conditions?
That one I'll let Dr. Zhang handle, I think.
I would say not necessarily. Sometimes I do have patients who have flushing, and that can contribute. Sometimes I have patients who have dryness, but if that's the only symptom, I would say if it's hard to say without knowing the whole story. So I would say I would defer that question to your doctor, but in general, I would say probably not.
Dr. Zhang, is mast cells why a patient could still have symptoms even though Dupixent controls the eosinophils?
I think I have to say at this point, I don't know the answer to that. Dupixent does decrease IgE, and IgE mediated mast cell activation does seem to be present. But I think that's a great question, but I don't have a great answer.
Julie Akers has a question you can ask.
Hi, I'm just wondering, so are you finding that Dupixent is, lessening the eosinophils in the EGDs, but the need for dilating is still there? I'm hearing some things about, the dilation is still needing to be done in the endoscopies, even though the eosinophils are not there. And I'm wondering if, could Dupixent be masking these somehow? Or the eosinophils being gone, but yet the symptoms are still there?
So we do know that the eosinophils are not the only important player here. We've seen other eosinophil ablating therapies that the esophagitis persists even though the eosinophils are gone. With that being said, our experience, and then kind of what I showed you with the studies from Dr. Dellin, and then some of the case studies on patients with fibrostenotic disease, so stricturing disease, would suggest that it does actually treat stricturing disease pretty well. And our experience has been the same, that we've had several patients who had stricturing disease requiring recurrent dilations previously, who we have not needed to dilate anymore once they went on dupilumab. It's not to say that it works for everybody. But I certainly don't think it's the opposite either, that it's masking things, or that we're seeing lots of patients that are getting worse or stricturing more on Dupixent. So for whatever that is
And
worth.
and sorry, is that when you're saying that other illness you were talking about, is that sort of like Ehlers-Danlos syndrome? Is that a sort of version of that, or no?
No, so when we're talking about fibrostenotic disease, sorry, I should have been more specific about it. So when we think about eosinophilic esophagitis or a lot of GI inflammatory conditions, we think of things being on a spectrum from truly just inflammatory disease, where you just see inflammatory cells like eosinophils or neutrophils, to progressing in a lot of cases to stricturing disease or scarring down disease. So that's what fibrostenosis means. So stricturing EOE is a fibrostenotic form of EOE. So that's what we're saying. So when we say we're treating patients who have fibrostenotic disease with Dupixent, those studies looking at that is patients who had strictures specifically. So it does seem to treat those patients but at least as well, if not better than other therapies that we have.
Okay. Is there anything effective for treatment for EOG symptoms that are still persisting after you achieve remission?
So that's for EOG that's the $1 million question. So question number one is what therapies consistently achieve remission for those patients, and I think that's hard enough in and of itself. I would say, I think that's where maybe we're casting at straws, but we look at things like mast cells. We look to see are there other therapies that might help. I think it really depends on the specific symptom. We still use thing on the pediatric side. We will still use some of the older medications, the periactins and acid suppressing medicines. Sometimes we've had good luck with using mast cell stabilizers. It just depends on the symptom and the patient.
Dr. Mukada, there's a question. After eating and sneeze and then sneezing several times after you have eaten, and when they do allergy testing, the results are always 0. Do you have an explanation for that?
So let me make sure I understand the question. So patients who have EOE and
right, patient has EOE. Yep. They've eaten the meal, then they sneeze quite a few times after eating the meal, and so they went on to do allergy testing with the allergist. Yep. And there's 0 results. The blood work is 0 for blood work. Yeah.
That's it's an interesting question. I think it's hard for me to know. I mean, I think sneezing in and of itself is not a typical symptom of EOE per se. I don't know that I have a good answer for that. I don't know, Dr. Zhang, if you have any other thoughts. that's presuming that the EOE is under good control, but it's not typically a symptom we see with EOE.
I've seen that in patients with like non-allergic rhinitis, or in some cases like almost a gustatory rhinitis. Some patients are particularly sensitive to spicy foods or smells, and so even though it's not allergic, it's kind of a like a non-allergic type of reaction.
Can a patient try OIT while on Dupixent?
I'll go with Dr. Zhang again. Actually, I'm interested in the answer to this. I've heard
Me
some
too.
conflicting things.
So this was actually hotly debated at the recent local allergy meeting with some of the different allergists will approach this in different ways. I think in private practice, it seems like more allergists are leaning towards, if we know that food is a trigger for EOE, we're not going to do things to worsen that, even if they are on Dupixent. And then other more academic allergists seem to be leaning towards, well, not every food is a trigger food. So if they're getting monitored by scope, then it's reasonable to do food reintroduction as long as we're monitoring their response and everything else is continues to be in remission. So it seems like people do it different ways, and it's a personal conversation between the patient and the allergist.
Is there genetic testing for EOE?
There is not a gene test for EOE per se, just like there's not a blood test for EOE. There are a number of genes that have been associated with the development of EOE, but I think what we are likely going to figure out over time is, the EOE, we know for sure EOE is not a single gene disease. It's not like cystic fibrosis or something where you can look for specific mutations and then say, if you have this, you have X% chance of developing the disease. And what I think we'll realize is different patients have different combinations of mutations, and that's probably why different people present differently and respond to therapies differently. So it's kind of going to that idea of eventually getting to personalized medicine. But no, there is not a genetic test for EOE.
Is it recommended not to eat what you've tested positive for on an allergy test for your EOE?
So I'll give the non-allergist view here. So skin testing for EOE is not helpful. So it is a way of identifying food triggers. We've seen patients who test positive for foods that they've been tolerating all their life and does not affect their esophagus when we take it out. We've seen patients who test negative, who, if we take the food out of their diet, it does, they do significantly better. We see that a lot of times with milk, for instance. We all used to try to skin test everybody. And what we realized is that the empiric elimination diets perform just as well. I do have some concerns about the potential, if you are someone who has tolerated a food, again, as a non-allergist, if you've tolerated a food without having anaphylactic reactions, but test positive and then stop the food and reintroduce it, is there any concern for actually then reacting with an IgE-mediated reaction? So we don't skin test routinely.
Are you seeing, this person is not located in the US, so are you seeing more transnasal for initial scopes, as well as increased use of other methods used during surveillance like sponge or string? And she just apologized ahead of time because she's not from the US.
Sure. So transnasal endoscopy is expanding in prevalence across the country. There's I think there's now about 45 pediatric centers that do transnasal endoscopy. There's less adult centers that do it. We do them in Cincinnati. There's 3 of us that do transnasal endoscopy. Not every center has it. There's advantages. There's lots of advantages to doing it in terms of not needing sedation. Most of the time, at least for us, we use bronchoscopes. So we do transnasal esophagoscopy. I would still generally prefer a traditional EGD for your initial endoscopy because we get a much better view with the high definition scopes that we have. The other thing is the transnasal scopes are very small, and so it is difficult to really assess the caliber of the esophagus because the scope is so much smaller than the esophageal diameter. So unless you have a pinpoint stricture, you're not going to necessarily pick up on it with the transnasal scope. I think they're great for, we get good biopsies with them. I think they're great for surveillance. We have done it for the initial scope for a few patients. It's not my preferred way to do it. We are starting, and we and others are starting to do full transnasal upper endoscopy. So going stomach and small bowel as well with the longer scopes.
Can a live vaccine trigger an EOE flare?
Not that I have seen.
Okay, the next question is, have you seen infants go into remission from EOE and be confident that they have been cured if it's not still come back in 7 years, or should you assume that they always keep rescoping? So I guess I should have reworded that. I apologize.
No, that's okay. I think I saw that question earlier and I was trying.
Okay.
Yeah, I mean, I think. So I guess the answer is it depends. So if you're on a therapy that it hasn't come back, that's different, right? So if you are in that small percentage of patients, and there does seem to be a small group of patients who we'll say outgrow or for whatever happens, they don't, their EOE does not seem to be persistent, but it seems to be far less than 1%. So I have very few of these patients. If you are back on a full diet, not on medications that are controlling things, we typically will have patients come back for a scope after a couple of years off of all therapy. If you're doing well and asymptomatic, I don't necessarily know that you need to be rescoped from that point forward, but it is such a small number of patients that sort of fit all of those criteria that it's hard to generalize. If symptoms come back again, I do think you need to get rescoped because I will say I have at least 2 patients who graduated from me feeling pretty good not on any therapy who called me later as adults and said, hey, I just wanted you to know for future reference, I'm starting to have symptoms again. I'm going to go see an adult GI doc.
Do you have any concerns of long-term therapy with a PPI or steroids causing osteoporosis?
Great question. Do I have concerns? I always have concerns. Have I seen it? No, I would like to reduce people's doses when possible. I'm probably more concerned. I will say now that we do have things like Dupixent and some of the other steroid therapies, I'm much less likely to keep people on chronic high dose PPI therapy. So kind of the adult dose twice a day. I typically try not to use that long term. I can't say that I have compelling evidence to say why, that's any more likely to cause bone issues. We looked retrospectively at our own bone density data here several years ago. It's very hard to really tease out the total steroid and PPI exposure to patient based on patient records, but PPI use was mildly associated with decreased bone density. Steroid use was not. That's a very limited sample, but you know, we did not, and to be clear, steroid use when we're talking about topical swallowed steroids for EOE was not associated with decreased bone density. If you're on prednisone or systemic steroids, that is a different matter if you're on those chronically. And I think even the inhaled steroids, you're likely to have more systemic exposure than when you swallow these particular steroids.
What about a patient with EOE who has 0 allergies? Is Dupixent really the right drug for these patients?
Again, I don't think it's a necessary drug by any means. Like, I don't know that there's one that's, if you're doing well, I don't think there's a reason to move to Dupixent just because. I don't have any evidence to say that it's going to have long-term benefits for that patient. You know, that's exactly the kind of patient that I would say, you know, if you want to do it, I think it's fine, but I don't think there's any compelling need to do it.
If it's a patient with severe EOE, though, they should,
I think it depends on how they're doing, right? It depends. If you're refractory, if you haven't responded to therapy, then no, then yes, I think you should try something else to treat it more effectively, and hopefully Dupixent is the answer there. I think we've had patients who, you know, had stricturing disease or presented with food impaction, so presented with pretty severe disease, who've been doing great for, you know, 10 years, 15 years on their steroid therapy, and you know, if they're doing fine, I think that's fine for them.
any patients on Dupixent for EOE and allergic issues who also have EDS report any additional joint pain from the Dupixent?
In my limited, so we really have not seen many patients, and I do ask about joint pain on all of these patients. We have not had as much joint pain as I thought we would. Really not enough for me to be able to generalize. I will say one of my patients who had joint pain with Dupixent also had joint pain preceding Dupixent, and does have some hypermobility issues. So, you know, we have both said, I'm not sure what's actually causing this. Is this worse? Is this worsening of the underlying hypermobility? It's hard to know. More to come there. So it's a great question, but we just don't know enough.
Is there some relation between EOE and hereditary angioedema?
I'm going to defer again to my allergy colleagues here.
They're both very rare in terms of what we know of their pathophysiology. There's not a ton of overlap. I don't know that there is increased incidence of HAE and EOE.
Dr. Mukada, if a patient has severe EOE but no food allergies, Dupixent would be the right drug for them or not?
Severe EOE but no food allergy.
Does it matter?
So Dupixent doesn't really treat food allergies per se. You know, it's really treating the other allergic conditions. So, you know, again, things like severe rhinitis where you have polyps in your nose, eczema, chronic urticaria, asthma. I think so it will treat those other things. It won't help food allergy. It will potentially, to your earlier question, the severe EOE patient, if you're not getting relief with what you're doing, I think it may still be the right drug to try for sure. If what you're doing isn't working, I think, you know, that we now have other options. So I think it's worth trying.
For adults with osteoporosis, is steroid therapy safer than a PPI? And what are the risks and side effects with long-term steroid therapy?
Just trying to see if I have any of my adult GI colleagues. No, I don't. So anecdotally, I think I would probably err on the side of steroid therapy being probably more safer. Long-term side effects, we haven't seen many. We do worry about it. Someone asked somewhere in the chat about topical or oral or esophageal candidiasis, or yeast infections. But I have not seen significant infectious issues with them. I think by and large, I've been pleasantly surprised by how well people seem to tolerate the topical steroids. We do, it's not to say that everyone tolerates them well. We have seen patients who have had more systemic absorption, and in extremely rare cases have had to think about things like adrenal suppression, but it is the vast majority of patients do quite well.
Everybody, I think this has been just great session. So many questions, so many great answers and presentations. I think we're going to let Dr. Mukada and Dr. Zhang get on with their evening. We're so lucky that you guys were here with us to be able to answer all the questions. You can email Shay and I if you still have questions. She had put our emails in the chat at the beginning. We're happy to forward your questions on, get you answers, and get them back to you if you didn't get your question answered tonight. Thank you again for being here, and we look forward to seeing everybody tomorrow evening. And again, Dr. Spergel will be here on Friday to do his presentation, just in case you missed that. And thank you so much, Dr. Mukada and Dr. Zhang, for being here with us.
Thank you, guys.
Thank you.
Have a good
night.
evening, everybody.
Good evening.
Good evening.